Welcome to The Explainer. Today we're jumping into a topic that, if you're an oncology pharmacist, is an absolute must-know: testicular cancer management. We're going to focus on the high-yield, board-relevant info that you need to know for your practice and, of course, for that BCOP exam.
So, here's our game plan. We're going to follow a patient case right from the beginning, figure out their risk, and then we'll explore the different treatment paths for seminomas and non-seminomas. And to wrap it all up, we'll hit some really critical chemotherapy pearls. All right, let's dive right in.
You know, every treatment plan, every decision we make, it all starts with a single patient. So we're going to kick things off with a pretty typical clinical scenario, because how a patient first presents really does set the stage for everything that comes next.
Okay, meet SD. He's 26, he's just had surgery, and the pathology is back. It's a non-seminoma. Now, we have his labs, and our very first job, our most critical task right now, is to figure out his risk using the IGCCG criteria. This one step is literally the foundation that will guide his entire treatment journey. So, the big question is, where does he land on the risk scale?
Before we even start talking about chemo regimens, we've got to understand what we're up against. What's the real burden of this disease? What's the prognosis looking like? And in testicular cancer, this all comes down to risk stratification. It's really driven by two key things: his tumor markers and where, if anywhere, the cancer is spread.
So, let's talk markers, because this is huge. And here is a massive pearl for your BCOP exam. Seriously, tattoo this one on your brain. Alpha-fetoprotein, or AFP, is only made by non-seminomas. A pure seminoma will never make AFP. So if you see a patient with an elevated AFP, it doesn't matter what the path report says, there is a non-seminoma component in there and you have to treat it like one, period.
And you know, these half-lives aren't just numbers to memorize. They are one of the most powerful tools we have. After surgery or after a round of chemo, we are watching these markers like a hawk. They're supposed to drop at a predictable rate. If that AFP isn't cutting in half every week or so, that is a major red flag. It's screaming at us that there's still active cancer in the body and our treatment isn't working as well as we need it to.
Okay, so this table is basically the cheat sheet for non-seminomas. You can see how it's all about specific cutoffs for the markers and whether they're spread to places like the liver or the brain, what we call non-pulmonary visceral mets. So let's go back to our guy SD. His AFP is 500, HCG is 3000, and no non-pulmonary mets. You look at the chart, whoa, he fits right into that good risk category. And nailing that down is the piece of the puzzle we absolutely had to have.
All right, so we've got our patient SD sorted. But before we go down the non-seminoma treatment path, let's take a quick but really important detour to talk about seminomas. Their whole approach is pretty different, and seeing that contrast is really going to help you understand the full picture of how we manage these cancers.
For early-stage seminoma, the name of the game is surveillance. After surgery, just watching and waiting is the strongly preferred path. Now, sure, there's about a 15 to 20% chance it could come back, but here's the thing. We are so good at curing it if it does, so we really only think about adjuvant therapy, like one dose of carboplatin, for guys who are worried might not stick with the follow-up schedule. The whole philosophy here is to avoid over-treating these patients.
Okay, back to non-seminomas, and back to our patient SD. We know he's got good risk metastatic disease, but to really get why we're going to treat him a certain way, it helps to first understand how we handle the earliest stage, stage 1 non-seminoma.
So with stage 1 non-seminoma, everything comes down to one little detail on the pathology report: lymphovascular invasion, or LVI. If that's present, it means the cancer cells have started to invade tiny blood vessels or lymph channels, and that just cranks up the risk of relapse. So while surveillance is still an option, we also have to talk about more aggressive approaches, like a big surgery called an RPLND, or even a single cycle of chemo with a regimen called BEP. See, it's already a different conversation than we have with seminoma patients.
And that brings us to the real workhorses, the heavy hitters of testicular cancer treatment, BEP and EP. As you can see, they're both built on that super powerful combo of etoposide and platin-cisplatin. The game-changing difference is that B, bleomycin. And trust me, whether you include that one drug or not has huge implications, especially when it comes to side effects, and it's what drives so many of our decisions for patients like SD.
So for a guy like SD, good risk metastatic non-seminoma, we get to a major fork in the road. The standard of care gives us two fantastic, highly effective options. We can either do 3 cycles of BEP, or we can do 4 cycles of EP. So how in the world do you choose? Well, let's look at the evidence that actually helps us make that decision.
This is where we get into the nitty-gritty of the clinical trials that actually built our guidelines. And if you're studying for your BCOP, knowing these trials and what they mean for our patients is just non-negotiable. This is essential stuff.
So check this out. It really comes down to these two landmark trials. First, the LAURA trial basically proved that just dropping the bleomycin from a 3-cycle regimen was a bad idea. BEP for 3 cycles was just plain better than EP for 3. But then, the DeWitt trial came along and showed that if you give a 4th cycle of EP, it works just as well as the standard BEP. So the big clinical takeaway is this. For good risk disease, 3 cycles of BEP and 4 cycles of EP are considered equivalent. And that gives us a choice. If you have a patient who's a heavy smoker, has underlying lung disease, maybe even a professional trumpet player, avoiding that bleomycin lung toxicity by using 4 cycles of EP is the much smarter, safer way to go.
Now, speaking of toxicities, BEP is considered a high-risk regimen for febrile neutropenia. We're talking over a 20% risk. And whenever you see that number, it should immediately trigger a question in your mind. What about growth factor support? Should we be giving something like GCSF with this chemo?
And this brings us to a super important, kind of nuanced clinical pearl. For a long time, there's been this theoretical worry that giving GCSF could actually make bleomycin lung damage worse. Now, it's never been definitively proven, but the concern is there. So what do? We don't give GCSF to every single patient right out of the gate for primary prophylaxis. However, and this is the key part, it is not contraindicated. If a patient gets a neutropenic fever, we absolutely use it for secondary prophylaxis, or we might use it up front for a patient who has other high-risk factors. It's all about using it smartly, not just automatically.
And finally, let's step back and remember why we're doing all this. The cure rate for good-risk testicular cancer is over 95%. That's incredible, but it means our job is not done when the last cycle of chemo is infused. The whole conversation has to shift to long-term survivorship. For a 26-year-old like SD, we're not just thinking about next year, we're thinking about the next 50 years. That means being proactive about managing long-term risks, like heart disease from cisplatin or secondary cancers from etoposide. And critically, it means having that talk about fertility preservation before a single drop of chemo is given. Curing the cancer, that's the first win, but ensuring our patient gets to live a long, healthy life afterward, that's the ultimate goal.